And I would like to thank Dr. Sanjay Chandan, Dr. Narayan Pandey sir, and Dr. Bhushan Bhagat sir for guidance. These are the questions that we are going to be discussing today. The advantages of extracting impacted teeth at an earlier age. Name the contraindications of infraorbital. Name the signs and symptoms of trigeminal neuralgia. Classify suture materials. Name the contraindications to the use of bone plates. And signs and symptoms of chronic maxillary sinusitis. State the contraindications of exodoncia. State the adverse effects of carbamazepine. Name the anatomical boundaries of submandibular space. Differences between cellulitis and abscess. So the first question is extracting teeth at an earlier age. So the most surgeons advocate that if you think that a tooth is very unlikely to erupt, so as a prophylactic treatment, you should remove it. So that is because the first point is the root formation is incomplete. So if you extract the tooth between 16 to 20 years of age, then the procedure becomes easier. The younger patients may tolerate the procedure better. The healing is faster, bone formation and periodontal regeneration is better. And it is believed that if you remove the tooth as a prophylactic step, then it will prevent periodontal diseases, caries, infections, cysts, etc., that are likely to be associated with the impacted tooth. So the also prone to infections such as pericoronitis. This can be avoided if the tooth has already been removed. The nerve injury is a complication that may occur with impacted teeth removal. So if this happens, then at an earlier age, the recovery is better. The presence of an impacted tooth on the region of the angle of mandible weakens the region. So if by chance there is an injury, then it is more susceptible to fractures. So this may be prevented by prophylactic removal of the tooth. The next is the contraindications of intraorbital nerve block. So in discrete treatment areas where only one or two teeth are there, then supraperioral is preferred. Hemostasis of the localized area, when desirable, cannot be adequately achieved with this injection. Then local infiltration into the treatment area is indicated if there is a wound in the area or if there is a canine space infection. Name the signs and symptoms of trigeminal neuralgia. So the trigeminal neuralgic pain typically arises in persons who have no abnormal neurologic deficit, such as loss of corneal reflexes, anesthesia, paresthesia, muscular atrophy, or weakness, etc. So trigeminal neuralgia typically manifests as sudden unilateral intermittent paroxysmal sharp shooting, lancinating shock-like pain, elicited by slight touch superficial trigger points, which radiates from that point across the distribution of one or more branches of trigeminal neuralgia. So the pain is usually confined to one part or of one division of trigeminal nerve, mandibular or maxillary, but may occasionally spread to adjacent divisions, or very, very rarely, it may involve all the three divisions. The pain rarely crosses the midline. The pain is of short duration, lasts for a very few seconds, but it may recur with variable frequency. Even though there is a refractory period, which is like a complete lack of pain between the attacks, some patients report a dull ache in between the attacks. During an attack, the patient grimaces with pain. You will see him clutch his hands over his affected side of the face and stopping all activities. And he'll just rub his face, which may redden. And you'll see his eyes watering until the attack subsides. So because of the pain, the male patients avoid shaving and they avoid brushing. So you'll see a poor oral hygiene in these patients. So the paroxysmal cycles last for weeks or months, and with time the cycle appears closer and closer. With each attack, the pain seems to become more intense and more unbearable. In extreme cases, the patient will have a motionless face. It's called the frozen mask-like face. The presence of an intraoral or extraoral trigger points provocably by obvious stimuli is seen in trigeminal neuralgia. The trigger zone is an area of the patient's skin or oral mucosa where low intensity mechanical stimulation such as light touch or an air puff or even touching face at a particular site or by chewing or even by speaking or smiling, brushing, shaving, etc., or even washing the face can elicit a typical pain attack. The location of the trigger points depends on which trigeminal nerve is involved. So in V2, which is the maxillary division, the points are located on the skin of the upper lip, ala nasal, cheek, or on the upper gum. In V3, which is the mandibular nerve, this is the most frequently involved branch. The trigger points are seen over the lower lip, teeth, or gums of the lower jaw. Tongue is rarely involved. Then the V1, which is the ophthalmic, this is the rarest nerve that is involved. The trigger zone usually lies over the supraorbital ridge of the affected side. The characteristic of the disorder that attacks do not occur during sleep. Many patients will lead a very poor quality of life because of excruciating pain. It is very common for these patients to undergo indiscriminate dental extractions on the affected side without any relief from pain, because the pain of the trigger zone and pain fiber distributions often mimic pain of odontogenic origin. More than 50% of patients experience early remissions of greater than 6 months before return of active pain. So the next question is classification of suture materials. So they are classified by 5. So the first is according to the source. So they may be natural, synthetic, or metallic. So if it's natural, for example, silk or catgut. Synthetic like polyglactin, it is also called vicryl, or polyamide, or also called nylon. Metallic like a stainless steel wire. Then according to structure, so it may be monofilament like polypropylene, catgut, nylon, or multifilament like silk or polyester. According to the fate, so now some are absorbable. Absorbable are the ones that undergo degeneration and lose its tensile strength in less than 60 days. So they are catgut and polyglactin. Now non-absorbable are the ones that still maintain their tensile strength after 60 days. So these you usually don't, you have to have another procedure to remove the suture material. So it's like example silk and polyamide according to coating. So it may be coated or uncoated. So coated examples are silk, polyester, or braided or twisted nylon. And uncoated are stainless steel and monofilament nylon. There are also this different variety where they may be braided or twisted. So for example, nylon. Name the contraindications to the use of bone plates in heavily contaminated fractures where there is active infection and discharge. However, some surgeons advocate the use of compression osteosynthesis in such cases. In badly in badly communicated fractures where open reduction may pose risk of compromising vascularity in children having mixed dentition, where there's a danger of injuring the developing teeth buds, presence of gross pathological abnormalities in the bone. Enumerate signs and symptoms of chronic maxillary sinusitis. So the general symptoms are of maxillary sinusitis are severe throbbing pain when the pus remains confined within the bone in apical region. The intensity will reduce after 12 to 24 hours as the pus is discharged into the antral cavity. There is only slight swelling of cheek, so the patient complains of foul pus running down a nostril or presence of unpleasant taste. In case the tooth is periodontally involved, it may feel loose. Now, these are specific chronic maxillary sinusitis. There is pain and tenderness in the area of antrum is found usually in acute exacerbations, unilateral foul discharge through posterior nares, nasal decongestion, cacosmia, it is means of fatted odor with bad taste in the mouth. There is impairment of sense of smell. There is mild tenderness over the infraorbital region. There are multiple polyp formations. You'll also see a history of repeated attacks of acute mucopurulent rhinitis and a history of long-standing nasal or postnatal discharge in these patients. Sometimes this may also be asymptomatic. State the absolute contrast of exodontia. So if the teeth in recent irradiates within 6 months to 1 year, within 6 months of myocardial infarction after bypass surgery or stents, teeth in the area of central hemangioma, anteriovenous malformation, aneurysm, pregnancy in the first and the last trimester, site of malignant tumor, Hastings metastasis, leukemia, renal failure, uncontrolled diabetes, and cirrhosis of liver. So state the adverse effects of carbamazepine. So there is visual blurring, there is dizziness, somnolence, which is actually excess of sleeping, skin rashes, ataxia in rare conditions. So there's hepatic dysfunction, leukopenia, and thrombocytopenia. Aplastic anemia, it is known as should be monitored to avoid agranulocytosis. Name the anatomical boundaries of submandibular space. The floor is formed by myloid muscle, which is covered by loose areolar tissue and fat. Posterior medially, the floor is formed by hyoglossus muscle. The superior laterally, the medial surface of mandible below the mylohyoid ridge. The anterior superiorly, you'll see the anterior belly of digastric. Posterior superiorly, you'll see the posterior belly of digastric. There's also the styloid and there is stylopharyngeus muscle. Laterally, there is platysma, superficial fascia, and the skin. So here is the diagram. So here is the anterior belly of digastric. This is the mylohyoid muscle. This is the hyoglossus muscle. This is the hyoid bone. This is the styloid process. And then there's also a styloid ligament. Then this is the styloid muscle. This is the posterior belly of digastric muscle. And this is the middle constrictor of pharynx muscle. So the differences between cellulitis and abscess. So the duration of cellulitis is generally 3 to 7 days, and if it's an abscess, it is more than 5 days. The pain is severe and generalized. In abscess, the pain is moderate, severe, and localized. The size of cellulitis is larger than the size of abscess. The localization of cellulitis is diffuse and abscess will be circumscribed. Palpitation, there is hard, exquisitely tender, and in abscess, there is fluctuant and tender. The appearance in cellulitis will be a reddened area, and in abscess, you will see peripherally reddened. The skin quality in cellulitis, you'll see a thickened skin, and in abscess, there is centrally undermined and shiny skin. The surface temperature of abscess is raised, so it will feel hot or warm. And in abscess, it is moderately heated. So there is severe loss of function in cellulitis and moderate to severe in abscess. The tissue fluid is serosanguinous. peaks of pus is seen, and in abscess you will see puffs. There is severe malaise in cellulitis and moderate to severe malaise in abscess. The degree of seriousness of cellulitis is severe, and that of abscess is moderate severe. Predominant bacteria in cellulitis is all mixed, and abscess is predominantly anaerobic. Thank you.